Good morning, everyone. I welcome one and all to MCure's No Thrombosis workshop series in acute ischemic stroke. I, your host, Dr. Sanket Nevale, representing medical team at MCure Pharmaceuticals, welcomes you all to this exciting journey of case presentations, which are deliberated and discussed by the experts in the therapy with the course directorship of Dr. Asokan sir. With that note, I would like to introduce our course director, Dr. Asokan sir, who is a senior consultant neurologist, Sri Ramakrishna Multi-Speciality Hospital, Coimbatore. He has been the president, Coimbatore Neurological Society, president of the Tamil Nadu and Pondicherry Association of Neurologists, presented papers in national and international conferences on stroke and epilepsy, conducted various international drug trial studies in the department. Also has a special interest in stroke therapy. We have our moderator today, Dr. Puneet Agarwal, sir. Sir is a director neurology at Max Super Speciality Hospital, Saket. He has an excellent academic record. He has awarded the Health Excellence Award in Neurology from Central Health Minister in December 2016. Presented European largest series of thrombolized cases of stroke in India. Contributed many publications and chapters in peer-reviewed, reputed index journals and textbooks like Cochrane, Lancet, Seizure, Brain Research, and Epilepsia, etc. Thesis guide for DM Neuro, MD students, as well as PhD students. We have Dr. Rajneesh Kumar, sir, who will also be the moderator. He is a senior consultant and head in neurology and electrophysiology at Paras Hospital, Gurgaon. At Paras Hospital, sir has started thrombolysis in acute stroke, formulated a reputed electrophysiology laboratory, and provided clinical and therapeutic services with good clinical outcomes and patient satisfaction. He has been the principal investigator in multiple studies, internationally certified EDSS and UPDRS rater, written various public awareness articles in reputed newspapers. We have our expert speaker today, Dr. Nandini Priyanka. She is a consultant neurologist at Apollo Hospital, Trichy, and has presented paper and posters at multiple national and regional conferences. We have our second case presenter, Dr. Chandu Simba Sivarao, who is a consultant neurologist in Chandu Neuro Center at Vijayawada. He has a total work experience of 3 years as a consultant neurologist and is a specialist in stroke thrombolysis ENMG studies. With that note, I would like to hand over the session to our course director for his opening remarks. Over to you, sir.
Thank you very much, Dr. Vale. Thank you for your kind introduction of the speakers, moderators, and the chairperson, etc. First of all, good morning, all of you. And I thank all of you, first of all, for sparing time to attend this web meet today. I thank the team Connectors, that is MCure, especially Dr. Nevale, for organizing the meet. This No Thrombosis in Acute Stroke workshop has been on show since 1.5 years. We had the opportunity of discussion of many interesting cases and learned many things out of it. Definitely, this sort of interactive discussions useful both for the speakers, panelists, as well as participants. Once again, I welcome the moderators and the speakers for this excellent meet. And without wasting much of time, I think we'll go on to the first talk by Dr. Priyanka from Kochi, who is going to share with us an interesting case. Am I correct, Noelle? First case, Dr. Priyanka?
Dr. Priyanka, sir, no problem. Sir, before that, if the moderators would like to give any opening remarks, sir. Dr. Rajneesh, Dr. Puneet.
Yeah. So, hi, good morning, everyone. Dr. Ashok and Dr. Rajneesh and Dr. Sanket. So, I just like to make one remark that I've in Max Hospital Saket, we have used tenecteplase in few patients till now, although we have series of around more than 1,500 patients for TPA thrombolysis. But definitely for few patients, we use tenecteplase with a very good results. And it's a very good alternative for us, definitely, for in patients of acute stroke thrombolysis.
Thank you, sir. Dr. Rajneesh?
Hi. Good morning, everyone. In Paras Hospital also, we have been thrombolizing for a long period of time, and we recently started with tenecteplase also, and we had a very good results. We have already got about 7 patients that we have thrombolized with tenecteplase, having a very good results because we know that it's one-time shot that you need to give. So you have got basically the improvement in the needle to the basically drug time is very, very good in this condition, and we've got a very good results.
Thank you, sir.
Thank you. One minute, if you don't mind. Thank you, Dr. Rajneesh and Dr. Puneet. Excellent. And this I want to place in the card. Since 2010 we started, and we had till date thrombolized 510 cases, 510, and most of the cases, at least 90% only the tenecteplase, started with alteplase, and for ease of using, etc., we'll be knowing in the course of time. We have started using only tenecteplase. So 490 cases, something like the tenecteplase, rest alteplase. The results are good. And luckily, touchwood, the incidence of hemorrhage is very less with our cases. And yeah, but we started the department way back in 1989, and since then I'm in the same department. And we have the opportunity of thrombolizing. Thank you.
Right.
Lovely, sir. Lovely.
Okay.
Dr. Nandini, would you like to start the meeting with your case, ma'am?
Hear me?
Yeah, you can initiate the share screen and we can start the meeting.
Good morning, everyone. So sorry, my video is not telecasting. I don't know why. Anyways, I can share my screen. So thank you, everyone, for giving me this wonderful opportunity. I'm Dr. Nandini. I'm working as a consultant neurologist at Apollo Hospital, Trichy. So today, I'm just going to give you a short comparative case studies, which we saw in this department in Trichy.
Dr. Nandini, sorry to interrupt. Please close to mic because the voice is not very clear. Please.
What about now, sir?
Yeah, it's better now.
Okay. Shall I proceed?
Yes, please.
So, this presentation is about 2 middle-aged persons, around 50 years of age. Both are smoker and alcoholic, and both have presented with out of window that is more than 4.5 hours. And both have a history of massive MCA ischemic stroke. So this is about Mr. X and Mr. Y. Vitals are stable for both, but Mr. X had aspect score of 4, and angio showed M1 cutoff sign and T2 flare mismatch. But he had the NHS score of 37, but almost in an comatose stage. Mr. Y had aspect score of 6, angio had M1 cutoff sign, but NHS score was 18, and he also had T2 flare diffusion mismatch C. Imaging of first patient. So this you can see the diffusion restriction and the flare mismatch of left MCA territory. Some of the images showing the caudate, lentiform, M1, M2 territory and the cutoff signs, ADC. That was the first Mr. X images and Mr. Y. So this is of right MCA, cutoff sign and ADC. So M1, M2, and all those regions of mismatch is being seen, and the flare images is also shown. So what was the treatment given? Mr. X was not thrombolized because there was no consent from the family, not even for the intervention and not even for the thrombolysis. They want only the conservative management. And according to the NHS score also, he did not fit for the thrombolysis because of the poor aspect score and poor GCS, and it was a massive score. And unfortunately, he did not survive also due to sepsis and MODS. But Mr. White, even though he was out of window and he had a massive stroke, and we gave him a chance of thrombolizing with connectase, he actually survived. He did not proceed further for other intervention also. He started showing the improvement. He recovered very well, and he is able to come in OPD basis. He is able to walk now with the power of 4+5 in both upper limb and lower limb. So what is my conclusion in these two short case studies? Even if it is a massive stroke out of window and
voice is not audible.
Score.
Nandini ma'am, would you like to join
Right,
from your phone just to get the good network, because we are not able to hear you clearly. We can see your slides, but we can't hear you clearly. Ma'am. Is there any other network that you can join in from where we can have the discussion moving?
Can you hear me now?
Yeah, we can hear you now.
Should I go through from the first?
No.
So where should I begin with?
No, ma'am. You can stop sharing your screen. We have seen your screen. Your screen was visible and clear. Your voice, which you were speaking, was not clear. So I believe there would be a lot of questions that would come to you from our panel. I think you can stop sharing and we can have the discussion moving.
Okay, Dr. Priyanka, thank you for your excellent cases. I'll start the discussion and then go to moderators. No, I'd like to see, you would have done MRA also, isn't it, along with the stroke protocol, along with the other images, DWT flare. What did it show? That's angio, MR angio.
It was showing MCA cutoff, M1 cutoff.
M1 occlusion, both the cases.
Yeah, both the cases.
That's one thing. The second thing, and the second case, out of window period, how many hours out of window period?
Both were actually wake-ups. So we don't know. Anyways, they were presented within 4.5 hours after the wake-up, but we don't know what is the onset of stroke, time of onset.
Yeah, there's now in anterior circulation, only 4.5 hours allowed, but now there is extended window period. Like in your first case, if there is mismatch, that is DW positive and flare iso intense, still there are people for lysis, because we go by tissue window rather than by time window. So that's why I asked. Time we really do not know. But your second case also, flare, it was iso intense, isn't it? Not hyper intense.
Iso intense.
So if it is iso intense, I think then it's not matter, right? Up to 6 or up to 9 hours also, because the wake up strokes, that's what we have been doing. So first case, anyhow, we could not do, they were not willing. Second case, he got improved because probably his flare was iso intense and could improve. That's what I feel. But ideally, yeah, that's what you have done is correct, the second case. So please, now I call upon Dr. Rajnish Kumar for his excellent comments. Yes,
yeah, because this, especially in a wake-up stroke, you do have those times you need to see the flare. It was iso intense, so that's a good thing, and you could thrombolize. So I think that's the right way of going approach and getting the things done. And he improved because of that. And when we didn't do the first one, he deteriorated secondary to that. So I think we need to thrombolize. That's what we need to see in these patients.
Dr. Puneet?
Yeah, so if you see, Dr. Nandi, first I'll congratulate you to do a thrombolysis on the second case. Although if you see the data in terms of LT plays, we have wake-up trial in which we are doing beyond window period with the patient coming within 4.5 hours from onset of symptoms. and it has shown a favorable response, and there is a class 2A right now recommendation for thrombolizing with the alteplase. With the tenecteplase going beyond window period, as far as I know, the certain trials like tempo and the twist trials are going on, which are going beyond window period, in which out of that twist trial they are doing for the wake up stroke. Results are still yet to come. But if you see but the approach we have found similar to alteplase, the patients who are having a large vessel stroke coming as a wake up, and there is a flare diffusion mismatch, as in your case, you can go with the tenecteplase also. With the only issue will be a medical legal thing, because till now Indian Stroke Association has approved up to 3 hours. And if something happens, we have to see whether how can we defend ourselves medical legally. That's the only thing, but it's a good approach. It can be definitely later on. I am hopeful that tenecteplase will come as a in wake up stroke similar to alteplase. And second is that the thrombectomy was tried in this case or not, because patient was having a large vessel stroke after once you have thrombolized. The reperfusion rate with alteplase is hardly 12-15%. I think the tenecteplase will also be having a low reperfusion. Although luckily you have a good outcome, it means there will be an opening of the vessel there in your case especially. But thrombectomy, have you tried for thrombectomy in that case or not?
Started improving. Patients started improving, sir. So we did not try for any thrombectomy. We did not try for the
right. So if I differ slightly on that context, so even if you see the ASA recommendation and AHA recommendation, we should not wait for patients who are eligible for the thrombolysis followed by thrombectomy in the large vessel. You should not wait for the recovery to occur. So even the patients in all these cases, they should be given a priority to give the thrombectomy if the center is having that facility, because the patient may improve further if you go for the thrombectomy, irrespective of waiting for the recovery. That's my concern. That is my opinion, but it may differ person to person. But that's a standard recommendation nowadays.
Yeah, totally agree with Dr. Puneet Agarwal. LVO, any LVO, that's what you try thrombolysis, and still pure thrombolysis itself, 10-15% they work, and vessel is getting opened up. If the facility is available and the patient rather affordable, probably you can bridge the therapy with thrombectomy. That's okay. But if the patient can't afford and having expended everything, and the center doesn't have the thing, and if the patient improving already, maybe you can wait. And of course, as Dr. Puneet said, it's rather recommend only up to 3 hours your connected place. 3 to 4.5 hours, even though we say 4.5 hours, 3 to 4.5 hours. Maybe medical legally, it's safe to use alteplase, but practice, we have been using till 4.5 hours. And the ACT trial also has come out. That ACT trial, now they recommend 0.25 milligram per kg body weight, and they have compared with the alteplase 1:1 randomized trial, and Vijay Mohan, we had published in May 2022. Results are good. Thank you, sir. Thank you.
Ashok sir, to add a few things, there are again, 4 trials 4 to 5 trials which are undergoing for this tenecteplase in this late onset window periods or wake up strokes, like the Chablis T trial is going down, external LVO for an large vessel occlusion. So then you got a Rose TNT and Timeless trial. So I think in years to come, we will have some type of basic recommendations for tenecteplase also in wake up strokes and all.
I hope so. Thank you. So thank you, sir. Thank you for your excellent participation, both of you. Now, shall we move on to the next case?
Yes, sir. I would like to invite Dr. Chandu, sir, to share his screen so that we can have the presentation moving.
Yes.
Am I visible, sir? My screen is visible, sir.
No, sir. We can't see your screen.
Wait. 1 minute, sir. Small.
There's a green colored up arrow, so if you can just click on that on the bottom of the screen.
Yeah, am I visible now, sir?
Yes, it's visible. Now you can get into full mode.
Yes. Now
Perfect.
get into good morning, everyone, my respected professors and colleagues. I, Dr. Chandu Samsara, consultant neurophysician at Chandu Neuro Center, Vijayawada. At the outset, I would like to thank MCUR for giving me this wonderful opportunity to share my experience of interesting case on thrombosis. And hereby I am presenting two cases. First case was a 65-year-old male presented with weakness of left upper limb and lower limb since 1 hour. He had history of long-standing diabetes and hypertension, which is partially controlled according to his relatives. And as he is satisfying for a window period, so we immediately done MRI brain plane. And here diffusion weighted image is showing faint area of diffusion restriction in the lower part of midbrain in the paramedian region, and corresponding ADC showing ADC reversal in the ADC imaging. So immediately we had the rest of the image doesn't showing any much significant changes except mild periventricular leukocytosis. So he was given tenecteplase at 0.25 milligrams per kg according to ACT trial. So immediately he was when he was given tenecteplase, his blood pressure was under control and the sugars also normal, and he was conscious, and he had shown mild improvement in the form of before giving the injection he had 2/5 power, and later on his power is improved to 4-5, and after some period he had worsening symptoms in the form of he became drowsy, and initially he was drowsy but arousable, and his weakness was remained same. So we repeated MRI brain imaging whether there is any expansion of the midbrain lesion involving the entire reticular activating system or some other thing to cause his drowsiness when electrolytes are normal. So when we repeated imaging, susceptibility imaging showing signal loss with in the caudate and putamen basal ganglionic region with blooming, with faint diffusion restriction in the corresponding region, probably acute hematoma in the corresponding region, and the original ischemic lesion doesn't show any hemorrhagic conversion in the scans seen. And to exactly assess the repeated CT brain also showing acute intrapharyngeal hematoma involving the basal ganglionic region without any intraventricular extension and causing mass effect initially. And we thought it as a remote parenchymal hematoma type 1 after thrombolysis, and we managed it conservatively after that. And again, when next day he was further deteriorated in the form of he becomes toporous with partially opening to the painful stimulus, and we repeated a CT brain showing hematoma is expanding, and also the corresponding surrounding edema is there in the perihematoma region with causing mass effect and midline shift, and there is mild obliteration of the perimesencephalic cisterna and transuncal herniation. This is that remote parenchymal hematoma type 2. Probably the hematoma and its secondary effects are causing the midline shift. So this is the case scenario about post-thrombolysis hemorrhagic complications which occur in the when very less percentage of people. This remote parenchymal hematoma usually occurs in 1.3 to 3.7% of the patients who underwent thrombolysis. Even though he was came in golden period and his hypertension and diabetes are under control at the time of giving infusion, he unfortunately had a remote parenchymal hematoma. Probably he might have microinfarction at that point, or microemboli, or any other things like cerebral amyloid angiopathy or other things might be contributing to it. And this is a rare complication which will be seen in usually 1.3 to 3.7% of the patients in general population who are given a thrombolysis according to most of the clinical trials. And next, my next case is.
Sorry to intervene. Can we go for discussion this case? Because we don't mix up both the cases. This is very interesting. Definitely. Dr. Rajnish Kumar, your comments please on this.
First, I would like to know, what was the final outcome of this patient, Chandu? What happened after that?
Now he was stop-press and intubated, sir. He was in comatose state now today, and he was on ventilator with E2, VT, and M3 response, sir.
Okay. Yeah, so because these type of things we have to take out, that whenever we are doing a thrombolysis, we are going to have some type of side effects, and we have to be ready for that. So that's one of the cases that we had a bleed in this condition. So we have to take it, explain to the attendants. That's what we can do in this patients.
Okay. Dr. Puneet?
Yeah. So I think it's really an interesting case. As you rightly mentioned, few cases, I think as far as I know, 2 to 3% can develop a extra ischemic hematoma, hemorrhage, which was a study done for especially with the multiplays in the past. And the commonest reason you rightly pointed, I think in your MRI, can I see the first MRI or any evidence of amyloid angiopathy in the first MRI, or any scenes related to like amyloid changes there in the E2 or those sequences? So if you see that, can you just see the slide there? Or, yeah, this one. Yeah, so except the mild cortical atrophy is nothing like there is a black spot here. If you see here on the left side, I don't know. Is it a normal hypointense normal thing in the MRI, or? So the only point is, I think we should review the case that to rule out any amyloid underlying angiopathies, or a case having atrial fibrillation, having a recurrent emboli going on up, or having underlying AVM, which can lead to bleed at the remote side. So you can review your case again. Second is that what was done after the hemorrhage? Did you give the cryoprecipitate or fibrinogen concentrate in this patient after that?
No, sir.
Hello. Because it's definitely a significant size of bleed which happened after, even in the remote side with the mass effect. So have you given any cryoprecipitate or fibrinogen concentrate after the hemorrhage?
Actually, initially we thought this was not causing much of its consecutive mass effects. So we managed conservatively only, sir. Later on, he was deteriorated.
So I slightly differ in this, that I think if the patient deteriorating clinically and with the hemorrhage, so irrespective, even if it is a H1, S2 or a PH1, you can say hemorrhage, with the clinical deterioration, we should give a cryoprecipitate or fibrinogen concentrate immediately to this case, so that because later on there was a hematoma expansion in this case, so you would have prevent that. if we have given this. That's my perception, besides controlling the other risk factor, and again reviewing the coagulation parameters if anything wrong going on, which can lead to this kind of remote hemorrhage. So that's one suggestion from my side. Yeah.
Thank you, Dr. Puneet. So my opinion, first of all, doesn't seem to be only due to tenecteplase injection, and maybe underlying pathology, as all of you have told, something like amyloid angiopathy. We could not see this SW images. SWI usually we get lots of microhemorrhages.
Yes, this was a SWMS, sir. After the patient had RPH.
Yeah, I see only one hemorrhage there, not lot of microhemorrhages. Okay, that's one thing. Another thing, of course, things
I
like
think right side there was a right parietal. You can see the black spot here. Yeah, where your cursor is in the SWI. So that was a the black dot on the right side in the right parietal area in the SWI.
But we'd like to see many microhemorrhages.
Yeah, hemorrhages are there, sir.
In a scenario like this. And another thing, of course, including coagulopathy. We don't know whether you ruled out coagulopathy. Age of the patient, I'm sorry, age of the patient?
Age of the patient, 6th decade, sir, 60 years.
60.
And he was non-alcoholic. And we worked up coagulation profile also, it was normal, sir.
Normal. So, but still, I think you have to look at underlying pathology. As told by Dr. Puneet, pressure, etc. And ultimately, you have to go for decompression. That's the thing you can do. But still, we don't know why he has blood. I don't agree only with tenecteplase, anticoagulation. Okay. So there is some other reason. Because we have also seen few cases of bleeding like this. A single large bleed, maybe single bleed, small or large. But growing hematoma, not very common with tenecteplase injection. Growing hematomas. This is occurring at a different place also with a large edema. So including some sort of angiitis, etc., that rule out. So this, and the first thing what we had shown is exactly the caudate nucleus. Now it's down, it's a little down. That's there in the caudate nucleus. So different places, hematomas. So this sort of scenario we get actually in venous infarcts. Different areas, multiple, or both hemispheres, growing, etc. We do get venous infarcts, venous hemorrhagic infarcts. Anyhow, did you do this venogram also? They would have done venogram also.
Not done for venogram. Actual patient is deteriorating, and we are planning for decompressive craniotomy, sir.
No, venogram normal, isn't it?
Not done, sir, venogram.
So these are my points. Probably that venogram, and ultimately I have to end up with the decompression at this stage. Thank you. Thank you, Dr. Chandu, for your excellent case. Please go ahead with the second case.
Move on to next case, sir. This is about how this case.
Yeah.
I'm moving on to next case, sir. This is a rare presentation of the common thrombosis which we encounter in our clinical practice. This is a 70-year-old who is non-diabetic since
slides are not. Your slides are not visible. Yeah.
Now I think I'm visible, sir. My screen
is visible.
Yes, sir. This is a 70-year-old non-diabetic since last 30 years and hypertensive since 20 years. He is husband of a gynecologist since last 24 hours. Initially, when he had paresthesia, so he was treated by his wife with gabapentin tablet. And later on, they are going to increase since last 24 hours. So they immediately rushed to the center, and when we had examined, we had low reflexes in the both lower limbs. TTR was down, and right side plantar was mute. But left side was at that time it was a XR, and as he is VIP patient and also clinical presentation, I had paresthesias and underlying distracts there. Both peripheral neuropathy like Guillain-Barré syndrome and also stroke was considered at that point of time. So immediately worked for both. MRI brain was normal at that point of time with the diffusion not showing any type of restriction in any area. And NCS was done showing sensory motor axial neuropathy with reduced amplitudes and also slowed conduction velocities. FAOs at that point of time normal without any delay. So he was treated conservatively with gabapentin tablet, and also in view of his risk factors, he was started on ecosprin and clopidogrel. As already he is using ecosprin, and clopidogrel was added at that time, and he was kept in observation in ICU. Later on, he had similar complaints in the left lower limb also, which is symptoms are progressing gradually to the opposite side of the body, and reflexes are down from the day one, and plantar was bilateral muted at this point of time, and at that point of time when he had progression of the symptoms, MRI was repeated, which again showed normal study, and when we go retrospectively asking questions like whether he had any fever or travel history or diarrheal illness or other things, he denied all the things. But meanwhile, when examined upper limbs also, the reflexes were down. So probably one possible etiology is as MRI scan even after 48 hours was normal. So ascending type of weakness pathology was spreading from the lower limbs to the upper limbs. So Guillain-Barré syndrome was suspected at that point of time, and on day 2 he was started on intravenous immunoglobulins for not taking any type of risk regarding his health. 2 grams per kg was started. When after IVIG is going, he again worsened on day 3 in the form of he went into quadriparesis, and is not able to move both lower limbs and upper limbs, and not able to speak also, and not able to swallow also. So finally he landed in Laughlin state. Again, after starting IVIG, he is worsened, and repeat MRI was done after convincing the attenders. And MRI was showing on that day there are tiny hyperintensities, diffusion distribution showing tiny hyperintensities in the ventral part of the medulla on both the sides. On left side, that hyperintensity is accentuating the upper medulla also, and the rest of the brain parenchyma doesn't show much significant lesions. These are the zoomed up images of the same. Sorry, I can't get the initial MRIs at quantum because they don't have any pathological lesions. The attenders deleted and didn't send me. These are the bilateral ventral medullary lesions, and also extending into the left medial medulla in the proximally, subcranially, and corresponding lesions showing T2 hyperintensities, faint hyperintensities, and T1 not showing any significant lesions, and ADC showing corresponding ADC reversal in the left medial medulla and also bilateral ventral medulla. Place showing, and also bilateral PCI arteries are visible, and also bilateral PCI arteries are visible, and left ICR, right ICR also in normal person caliber with the tunnel runs also seen, and the bilateral ACI arteries are seen. This case, I want to. This is a rare presentation of bilateral medullary infarction presenting clinically mimicking as GB syndrome, which is again masqueraded by the underlying diabetic status. with long-standing length-dependent neuropathy. Unfortunately, most of the posterior circulation strokes we couldn't pick up in the up to 30% of the cases. We couldn't pick up in the initial 24 to 48 hours. So when he had a strong suspicion and unusual clinical prognosis, unusual clinical presentation, we need to suspect the posterior circulation strokes with repeat MRI to find out the lesions. And this patient gradually worsened in the clinical status, and he was went on to the ventilator. Later, he developed sepsis, and he succumbed to that sepsis.
Thank you, Dr. Chandu, for this again second excellent case. Is a really tough case and very difficult. First of all, to recognize, first to localize the lesion, and then proceed with the treatment, and whether it is whether nerve or brain stem. So you're in a fix, and slowly you're sorted out. Anyhow, now I request Dr. Rajneesh Kumar, your comments, please.
Yes, yeah, this is a difficult case, especially a brainstem strokes are really hard to recognize and pick up also. But I would like to just add one thing, Chandu. Whenever you are, suppose you are very much sure or you think about that you have to go for searching for a posterior circulation stroke, when you are doing axial, one should also do a coronal ADC and DWI, so that at least if there is anything in there, it can easily be picked up. And if there is a gut feeling, you can always repeat it as quickly as possible and see if it is developing or not. Many times you will miss it, and coronal and other sections when you're doing ADCs as well as diffusion, you may be able to pick it and you can help the patients in them.
Thank you, sir. Dr. Puneet, your comments, please.
Yeah, Dr. Chandu, really it's a really excellent case, and it's a usual problem with the posterior circulation stroke. I think it's a very good example of stroke chameleon. Which is very common with the posterior circulation stroke, very common with the bilateral thalamic, bilateral occipital, and now you have medullary stroke. The only suggestion from my side is that, as Dr. Rajneesh rightly said, that once we are suspecting it in a high-risk case, so what we do here is that we are in the posterior circulation stroke, many times if we are having strong clinical suspicion, we are doing a diffusion 3000 also. So normally you do the diffusion 1000 and you see the infarct. But we have used it in various patients using the diffusion 3000, in which many times you can have a subtle bright signal which is not picked up in 1000, and which is correlated with the ADC also, because ADC always overread. So you can have a black in the ADC, but you should have a bright signal or a hyperintense signal in the diffusion also. So that is one suggestion. You can do that in the posterior circulation stroke if you have a strong clinical suspicion. The other thing, was the angio done on the first day? The angio.
Not done, sir. Angio was not done on the first day, sir. Yeah, only plain MRI with the diffusion distinction and ADC.
Only suggestion is that although you have found the left vertebral is hypoplastic, or I don't know whether it is really hypoplastic or some blockage was there in the left vertebra, or some dissection was there. We can't say. So I think angio should be done if you are suspecting posterior circulation on the first day. And sometime which can add to the diagnosis, it can help in making the diagnosis, like similar to cases like this, definitely. I think there may be some extension to, I don't know if it is locked in, maybe extending to ventral pons also, which is a commonest site for the locked in. So maybe extending there, which may not be picked up in MRI right now, but later on it may be picked up. Yeah.
Thank you, Dr. Puneet, for your very innovative comments. See, what I would like to tell, that's what, as you told, 3 Tesla. When you are in doubt about the posterior circulation, especially, what's the Tesla like, 1.5 or?
1.5 is Tesla, sir.
That's good. But always, of course, most of us are using 1.5, but 3 Tesla, that is also there. 3 Tesla invariably, if you strongly suspect posterior stroke, and if 1.5 Tesla is negative, there is no harm repeating this with the 3 Tesla. And as Dr. Puneet told, we have to look for vascular imaging, look for basilar occlusion or vertebral occlusion, vertebral dissection. If you suspect anything, go for vessel wall imaging in 3 Tesla. Not in all cases. In a tough case like this, where you had suspected initially stroke or started with something like peripheral. Now suspecting a stroke, posterior circulation stroke, probably 3 Tesla vascular imaging would have been helpful. And another thing, that's what. So the way you are presenting looks like it's a progressing stroke in the posterior circulation area, progressing stroke. In such as this case, usually we find something in the distal basal artery. Here, see, basal artery is filling up well, proximal to distal. And the only thing I can see is right PCA is slightly thinned out, but still the flow is there. Only thing is vertebral is hypoplastic. But people say one good vertebral with very good filling up of basilar is enough to prevent stroke, etc. But as Dr. Puneet told, if it is a dissection, vertebral dissection, that's a dangerous situation. Even if it is one vertebral, if it is a vertebral dissection, that's a dangerous thing. So in such a case, you can West imaging, you do nicely with the 3 Tesla. That's more useful. So these are my comments. Whatever it may be, now what's the prognosis? The prognosis of the patient. Sorry, you said the circum.
Yes, sir.
Yeah, that's it. So prognosis. This is rather, I feel, the progressing stroke in posterior circulation territory. Yeah, sadly we missed it. Rather, we lost the patient. I'm sorry, we lost the patient. Anything else, sir? Rajneesh and Puneet, you can add.
I think it's really very good, interesting cases were presented here. It's really, and they are usually a lot of time, especially in the posterior circulation stroke, we face a similar thing. You do first MRI, non-negative, second MRI. You have rightly said that 3 Tesla MRI sometimes may show something extra to the 1.5 Tesla, which can be tried if we have a suspicion. And definitely because these are the cases in which you can go for thrombolysis if you diagnose early. And even posterior circulation, you can go even up to, people have gone even for the intervention up to 24 hours. They have gone for 24 hours intervention, if possible, if there is a blockage of something is found. So I think would have been really interesting. And but the only thing is, just like similar to LT plays, I am very much hopeful that for the TNT plays also, the window period would have increased gradually from 3 hours to 4.5 hours and maybe beyond that also. With the new trials which are yet to come, Tempo and the Twist trial and the other Attest 2 trial which are yet to come.
Dr. Rajneesh, your final comments?
Yeah, my final comments is because posterior circulation, we have to be always be on our toes to see, if you're missing out something, try to repeat as quickly as possible. Dissection is very important here, so we need to look for it. So getting a repeated images done, getting a 3T done, getting coronal as well as an axial done, so that at least we can detect it out and treat as quickly as possible. That's what we need to look at in posterior circulation especially.
Thank you, sir. Thank both Dr. Puneet and Rajneesh for your excellent comments. We had a very good discussion today, and we had very good cases presented. First 2 cases also, what Dr. Priyanka had presented in part. The first case, of course, they were not willing. Somehow we lost. The second case, so that opened up. Simple connector place opened up. Opening up with mechanical thrombectomy, of course, thrombolyzed, the patient is improving. I think if the facility is not there, if the relative is not willing, still we can wait. Explain the risk to the patient and the relatives. That's it. So thank you very much. Thank you all. Thank you all. Now
thank you, sir. Thank you, sir, for the excellent deliberation. I believe I firstly want to thank our course director, Dr. Asukan sir, for your complete guidance for this course. I believe the series that we are doing with acute ischemic stroke, and somehow we are gaining confidence by discussing these cases. Everyone learns, no matter at what stage of life. I've always heard the mentors and the experienced professionals always come up and say that no matter how big or how experienced we become, but there is always a scope to learn. And I think this is a platform where the experience sharing and the experience, the publications and the confidence building and the wisdom to carry out to get the best patient outcomes, no matter what you have done for that patient, is the best from your version. But there is always a better version available outside, which can be discussed in this platform. I think that's what gives this platform a good flavor. The discussion which was flowing as I was hearing about the connected place getting into newer dimensions with longer, usage time, and I believe that also is a progressive trend that we see with the newer molecules that come in. Connected place is gaining that market in the very short span of time. It has reached a level with a confidence with everyone. I believe that pattern with the extended series of publications and studies will give us extra confidence. I want to thank Dr. Nandini Priyanka and Dr. Chandu Simbavasarao for giving their best cases today. I think those are the ones which have created the base for us for this discussion and has given new insights to each one of you and the listeners on the other end. I want to thank Dr. Puneet Agarwal sir and Dr. Rajneesh Kumar sir for their excellent comments behind every case that they have given to the patient, to the case presenters and the listeners outside as to what, when, how, and what are the other aspects that you need to think about. So thanks a lot, sir, and Dr. Asakan sir for your for the entire supervision and guidance for the entire series. Thank you all for the excellent morning discussion that we have today, and I hope you would have a great day ahead. Thank you all. Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Good day, all of you.
Have a good day.
Thank you. Thank you.